Hello everyone, this is Shadi Reis from ARS 2022. With me is Dr. David Cox. He gave a phenomenal talk about guideline for revascularization. So Dave, is still confusing, but we're getting there. So tell us the bottom line.
So Shadi, I think you know me. You and I are very close friends, and I think you know me. I'm a bottom line sort of guy. So first of all, kudos to the ACC, AHA, SCAI Revascularization Guideline Writing Committee. It's a tremendous amount of work. Mauricio Cohn, Sunil Rao, and a couple other names of people that I think our audience would know. But quite honestly, these people put their heart and soul into it. So we can have some points of contention perhaps, but I think they should be credited. So the bottom line, quite simply, is that the Guideline Writing Committee basically came out and said, for many things, CABG and PCI are going to give equivalent outcomes. The most important thing that has come out of the guidelines is that revascularization with either CABG or PCI is now a 2A, not a 2B. Love it to be class 1, but the evidence isn't quite there yet. But a 2A recommendation to prevent spontaneous myocardial infarction from ischemia, urgent revascularization, and here's the drum roll, cardiac death. So you can tell your patients that basically PCI saves lives.
Yeah.
Okay, and saves a lot, as we all know. The controversy here is that we all, diabetics with left main disease, we all think would do better with surgery, and many of those patients would do better with surgery.
Right.
So we need to do the heart team approach. Everybody needs to have some discussion. I think the guidelines did emphasize that it's patient-directed care. That is, we should come to patients and say, here's what the data shows, here's the controversies, what do you think? Yeah. Because you have a vote, you have the most important vote.
Right. Recovery time.
Exactly.
This versus that.
Not getting
Side
atrial
effect.
fib, the whole business. What is the controversy? The controversy is that the Society for Thoracic Surgeons and the American Association of Thoracic Surgeons and the European Cardiovascular Surgeons withdrew their support formally from the guidelines.
Wow.
And they did that for 3 reasons. They didn't feel that what had been class 1 now moved to class 2A for a lot of the surgical indications. They didn't feel that CABG and PCI should be viewed as equal revascularization techniques. And they didn't agree with radial artery conduits as a class 1 for coronary artery bypass surgery. So based on that, even though they had a representative, each of those organizations, the American ones, had one representative, not the Europeans, obviously, these are American allies, but STS and AATS had, and the chair of the committee is actually a surgeon from Johns Hopkins. So it's for the first time in my career that I've ever had these kind of revascularization guidelines not endorsed by our surgical colleagues. Does it matter? In one sense, I think it's a sign of the times, and I think we do have to make sure that every institution that we work at, we're working with our surgeons. Yeah. I think that matters more than what the societies do. Right. And hopefully, you know, we're not going to rewrite these guidelines for a long time. The important thing is these guidelines replace 6 guidelines. It's incredible. The PCI guidelines are no longer PCI guidelines. They're revascularization guidelines. CABG guidelines are no longer CABG guidelines. They're revascularization guidelines. STEMI, non-STEMI, stable ischemic heart disease. It's all under this one umbrella that took years to write. So we're going to live with this.
So but at least the data is there to support revascularization. Now, as you said, it would be nice to have a surgical endorsement from the society. But at the end of the day, we do our diligence. We present both options to the patient.
Right.
Decide this is what is going to save your life, prevent you from a heart attack or STEMI or something. And then we'll make them give them opportunity to speak to a surgeon as well as the side effect of PCI now.
Right. One other thing that I heard Michael Mack say is that we got to admit the data for surgical intervention is pretty old data. We're talking CAS, we're talking these old trials that are 25 years old. And so, you know, things have changed. I just hope that our local surgeons will take the high road and say, okay, my society may have not endorsed this, but, and we can argue about radials versus vein grafts till the cows come home, but, you know, that being said, we need them to help us honestly present things.
Absolutely.
You know, one of the things I struggle with the heart team, in a lot of institutions, you do the heart team and you get a surgical consult and you get surgery. You don't get a balanced opinion. And I think the guideline writing committee really tried to say that it really should be not a surgical consult. It should be a surgical consult as an option for your care.
Right.
And
so the way you put it, yeah.
Exactly.
But Dr. Cox, there's enough STS score, syntax data. Like we know it's like becoming almost very objective numbers. If somebody has STS score more than 4, I mean,
yeah,
like,
so that was interesting. There is endorsement for the STS score. That's a class 1. But I'll surprise you today. The syntax score is now moved to a class 2B.
2B.
Okay, so the Europeans still keep the syntax score as part of how they
evaluate
view
the
things,
patient, yeah?
but not so much the American guidelines. So kind of fascinating. You know,
And based on what? Why they moved that? So how are they going to evaluate?
They just, and so I would encourage all of us to, you can download the PowerPoint.
Yeah.
It's about 129 slides, but it's worth having that slide deck there. And the summary of the guidelines is actually a pretty quick read. And they sort of explain that, you know, syntax is a pretty rough tool to try and decide who should get. Now, we all know if you have a syntax greater than 33, you're probably, but I never calculated the syntax score. I just looked at that anatomy and said, that's going to do better. You know, we got a OM bifurcation, a calcified right cornea, and LAD diagonal bifurcation. I don't know what the syntax score, it's probably pretty high, but that's going to do better. So
that's right.
Just interesting. And I think, you know, we live in an age, obviously, of black and white and this versus that. And I just don't want these revascular guidelines to get away from the most important person in front of us, which is the patient.
Absolutely.
And that the patient should
100%.
have some options.
Yeah, absolutely. 100%. And always, sometimes you had it, I had it. You talk to the patient about both options, regardless how much you show them the evidence. Sometimes they are focused on one option. That's it. Regardless if you try to show them favoring, not pushing them, but favoring one option over another. If the patient wants something, that's it.
Right. And I think, you know, we're not dealing with patients in absolute black and white, right? It's a choice. And as long as patients make that choice, if somebody wants to choose medicines, then it's my job to figure out a way to maximize their medicines and live with it. We can always change course later. Now, obviously, to accept surgery is a big step. But I also think, you know, we talked about it in the session this morning, the idea of complete revascularization doesn't mean you have to stent every small obtuse marginal with a 90% lesion.
Right.
We're talking about major arteries, proximal narrowing. That's what you got. The CTOs, oh, that was the other thing. I'm sorry to go on, but the one thing that as interventionalists we're going to not like is the CTO recommendations were 2B and a lot of language about there's no evidence that shows the CTO provides symptomatic relief if you fix it. And you just gulp at that because it's a hard thing to prove, right? And I think it just underscores how much work we have to do in the CTO arena.
Yeah. And it's hard to recruit for these patients. I mean, there's some trials done before.
Yeah.
Show some benefit in heart failure, benefit in angina, but still, it's hard cohort to recruit.
It's hard. I mean, I haven't had it happen very often, but you'll take on a LAD, CTO, and you won't be able to cross it. And, you know, Bill Lombardi says this all the time, and I have to agree with him. then you got to send it to somebody that's better than you, or you got to send it to surgery.
Yeah.
Now, for the right coronaries and the circs, I don't feel as strongly, but there is, as you mentioned, some data for survival. So I was a little surprised that the guideline writing committee was
Just that low,
so negative about CTOs. But I think you're right. It's hard to recruit patients to this trial. We'll just live with it.
Dr. Cox, thanks so much for your time. Phenomenal
Jay.
summary of the revascularization guidelines. Please watch this video and others on ARS 22 YouTube channel.